This lecture is going to focus on looking at some pharmacokinetic principles in renal compromised patients. So remember that there are two major routes of elimination that a drug will undergo to be excreted from the body, and that is renal and hepatic elimination. So of course, patients with pathologies in either of these two organs will experience some difficulty removing the drug. And of course, if they experience some difficulty removing the drug, they're going to have toxic side effects or adverse reactions to these drugs, because obviously the concentration is going to be much higher than anticipated because the patients are not clearing these drugs out as effectively. So remember, creatinine is an endogenous substance. It's released by the muscle, and the rate of creatinine production is proportional to muscle mass. And the muscle mass is dependent upon, of course, the body weight, particularly lean body weight, gender, and age. And so the rate of creatinine production can be mathematically defined as 140 minus the age times the value, the lean body weight, divided by 72. Certain things can determine creatinine clearance. The most common method would be to measure GFR, and that will help you determine creatinine clearance. For patients with renal impairment, one can also use creatinine clearance to alter dosing regimens, which is kind of the purpose of this lecture. And there's a couple ways you can grab creatinine clearance. You can directly measure it, which is the most accurate. You can use urine samples to do so, or you can estimate using the concentration of serum creatinine. So in terms of creatinine clearance, you can eliminate creatinine obviously almost exclusively by the kidney, so it's a good measure for looking at kidney health. And the way we can kind of do this is that we can look at creatinine in the blood. If you see lots of creatinine in the blood or the serum, it's a sign of low clearance. And so clearance obviously is inversely proportional to the serum concentration. So if serum concentration is high, creatinine clearance is going to be low. And so the formula for this is the creatinine clearance for renal impairment is going to be the rate of creatinine production, which was defined mathematically in the previous two slides, divided by the serum concentration of creatinine. And this will estimate the rate of creatinine production and will allow you to measure the, and in order to do this, you need two things. You need obviously the rate of creatinine production, and you need to be able to measure serum creatinine levels. Sometimes you can, sometimes you cannot. So there's a few more formulas where you can kind of get some of these derivatives. And so this is basically just what I said. Here's the formula for creatinine clearance renal impairment. The rate of creatinine production divided by the serum concentration, which looks like this. Here's 140 minus the age times lean body weight. And then what we did is we put the 72 in the denominator down here. We just moved it over, divided by serum creatinine concentration. So let's look at an example. So for a healthy 70 kilogram 20-year-old male, here's their normal creatinine clearance. It's going to be 140 minus 20 times 70 divided by the 1 times 72. And so normal creatinine clearance for an average weight 70 kilogram 20-year-old male is about 120 mLs per minute. Okay, and so you can kind of use this information for some of your plug and chug calculations. You can also measure another function or another formula looking at kidney function. And so this is what kidney function looks like for a 70 kilogram male. It's the creatinine clearance that has the degree of renal impairment divided by normal creatinine clearance. So you can use this formula, 140 minus the age, divided by serum creatinine concentration times 120. So these are all derivatives basically of the same thing. This gets a little bit more complex. Let's kind of back up a little bit and extrapolate or focus on kidney function. Kidney function really has two mathematical formulas that you can use if you want to calculate somebody's kidney function. Obviously, if the reason you're doing this is because that they don't have normal kidney function, so you wouldn't calculate this for a patient that has normal kidney function, because the first parameter is the creatinine clearance, the impaired creatinine clearance, and so this is obviously coming from the patient, and then we all know what normal creatinine clearance is based on a normal sized patient. So that's one way of looking at it. Another way of calculating kidney function would be to take 140 minus the age and then divide that by the serum creatinine concentration for that patient times 120, which is normal creatinine clearance. That's where that comes from. So let's look at a few examples. Here's kidney function. And then, so this is for a male. If this was for a female patient, we would take this whole answer and multiply it by 0.85. Okay, so remember that. And then this is just kind of defining what our parameters are. So creatinine clearance is the patient's creatinine clearance. If it's renally impaired, this is kind of the focus of this. Serum creatinine is the serum creatinine of the patient. Normal for males is typically 0.6 to 1.2 milligrams per deciliter. Autocorrect keeps making it capital D. It's deciliter for males. And 0.5 to 1 milligram per deciliter for females. The normal obviously is based on the package labeling. So you can look up the normal creatinine clearance of a specific drug, and that comes from the package labeling. I'll show you what that looks like towards the end of this presentation. So let's go through an example here. Let me slide the frame over just a little bit because it's cut off. There we go. So a 40-year-old, 70-kilogram renally impaired man is prescribed an antibiotic. His serum creatinine is measured at 1.4. What's the kidney function of this patient? So we can just plug and chug. We've got 140 minus the age. He's 40 years old, so 140 minus 40. Okay. His serum creatinine is 1.4. Put that in here and multiply it by 120. So this guy's kidney function is 0.6, or about 60% of normal. Let's kind of expand on this. The same 40-year-old, 70-kilogram renally impaired man is given an antibiotic. The desired steady-state concentration is 10 milligrams per liter, and the the serum creatinine concentration is measured at 1.4. Normal clearance is 40 mLs per minute for a 70-kilogram individual. And then you've got some other pharmacokinetic parameters here: F, Fe, tau, or TOF. Kidney function is 0.6 from the previous slide. So we can use this formula right here. To answer the question, what is the clearance for this patient? So the clearance of a renally impaired patient is going to be this formula: 1 minus Fe, which is 0.7, times the value of 1 minus the kidney function. So what's the normal part of the functioning kidney? So that's where that comes from, times the normal clearance. And so start from the center, work your way out. Normal kidney function is obviously 1. This guy's at 60%, so basically he's got 40% working kidney, right? The Fe is the constant. That's 0.7. That's given to you. Typically, this is always given to you. We're more interested in having you calculate the clearance of the impaired individual rather than calculating the Fe. This is more clinically relevant. So we just plug and chug. Do your order of operations starting with parentheses first, and then you get 29 mLs per minute. And so the clearance of the impaired individual, this patient, is 29 mLs per minute, meaning this patient is going to take a little bit longer to clear the drug than similar patients who have normal renal function given the same antibiotic. How about a 40-year-old, 70-kilogram patient, same as before? Now we want to expand this and say, well, what's the dose that's required to achieve the desired plasma concentration? Earlier we said that the desired plasma concentration, or the desired steady-state concentration, is going to be 10 mLs per liter. So let's plug into this formula. What I did here was basically converted using unit analysis so that all the units can cancel out and match up. So here's the first parameter is clearance from before, 29 mLs per minute. The second parameter is the steady state concentration that we want, and that's 10 milligrams per liter. TOF, or tau, is the dosing interval, that's 6 hours. And then the kidney function, the bioavailability, F, is 0.5. Okay, and so because these units are not matching up, what I did in red was calculate out 29 mLs per minute times 60 minutes per hour times 1 liter per 1,000 milliliters gives you 1.7 liters per hour, and then that's where that number comes from. So 1.7 liters per hour is the new clearance times the plasma concentration times the dosing interval divided by the bioavailability, and that gives you 208 milligrams. So this patient should get 208 milligrams because he has renal impairment. So because the patient had renal impairment, just out of curiosity, what would be the dose required if the patient had normal renal function? So all we did here was we substituted the clearance for normal clearance, and we said that the patient had 40 mLs per minute, and we plug and chug, and we get 288 milligrams. And so even though this patient has reduced renal clearance, he's going to experience a relatively minor dosing reduction from 288 milligrams to 208 milligrams in the previous exercise. So the factors that affect creatinine vary: muscle mass, elderly age, sex, and so forth. Severe liver disease can affect creatinine. And remember that the rate of creatinine production and the excretion is directly proportional to the lean body mass. And so this has real-life applications. Here's what the Bactrim, which is sulfamethoxazole and trimethoprim, this is what the dosing guidelines look like. If the creatinine clearance is above 30 mLs per minute, you don't have to dose adjust at all. If the creatinine clearance is between 15 and 30, you should administer half the recommended dose. And if the creatinine clearance is less than 15 mLs per minute, you really wouldn't want to use this drug at all and just swap out for a different drug. All right, so this is kind of a return of pharmacokinetics, and this is more of an advanced topic because you're going to have to dose adjust a lot in patients that have renal impairment.